Assalamu alaikum wa rahmatullahi wa barakatuh. It is a pleasure to share with you this presentation today about the future of GLP1 receptor agonists. As you all know, we had been using GLP1 receptor agonist for diabetes indication and more recently for obesity indication. So the objectives of my presentation will be recognize the pros and cons of the current incretin-based mimetics, the GLP-1 receptor agonist, and the other combination of GLP-1 receptor agonist. And then we will overview the emerging GLP-1 receptor agonist for obesity and diabetes indication. So I will focus mostly about the obesity indication since we know the diabetes indication, but for the newer medication, I will review both of them on obesity and diabetes medication. So there is no doubt that centrally acting medication are very efficacious in management of diabetes and obesity. And I have been claiming this for many years, saying that obesity is a brain dysfunction. And now with emerging medications working on the hypothalamus for weight loss, we started to see significant results, not only on obesity, but in several cardiometabolic issues. So GLP-1 had been around since 2005, started with exenatide, a short-acting GLP-1. And from that time, several GLP-1 came, either once daily, like liraglutide, or once weekly, like dulaglutide, semaglutide, and more recently, combination of GLP-1 and GIP, tirzepatide, which is also once weekly. Someone will ask, what is the difference between these molecules? The core native GLP-1 is exactly the same. The difference, as you can see, is the percentage analogy of those receptor agonists with the native GLP-1. So, for example, liraglutide, 97% of all the amino acids and amino acid sequence are similar to the native GLP-1, while others may be a little bit different, like semaglutide, around 94%. The current three medications approved for obesity indications are liraglutide, semaglutide, and tirzepatide. And the three of them have been approved over the last 10 years. As you know, we had been using them for diabetes indication, liraglutide up till 1.8 milligram, while for obesity indication, it is 2.4 milligram and 3 milligram. For semaglutide, again, we had been using for diabetes indication up till 2 milligram per week, and for obesity indication under different name, 1.7 and 2.4. And then tirzepatide is the only one which is used at the same concentration for diabetes indication and also for obesity indication. So the maximum dose is 15 milligram once weekly with a slow escalating dose. So let me first go back and remind you with liraglutide effect at the maximum dose, 3 milligram, and also at the 2.4 milligram. And as you can see, over 20 weeks, was a relatively short period of time, the weight loss is between 7.5% to 8.5%. So there's once daily indication, convenient for some people who can tolerate once daily. And as you can see, the weight loss is not a bad weight loss. It's a very good amount of weight loss, and especially it is a short period of time. Semaglutide is more powerful. And as you can see from the New England Journal of Medicine publication about its use in obesity, there is a staggering, very good amount of weight loss, around 16% weight loss at the 1 milligram, at the 2.4 milligram dose. and this over 68 weeks. So the efficacy of weight loss is very impressive. But the most important is the number of or the percentage of people who lost more than 10%. You can see around three quarters lost more than 10% of their body weight, and around one half lost more than 15% of their body weight, and nearly one third lost more than 20% of their body weight. Very impressive, as you can see, amount of weight loss. And then came tirzepatide, and as I told you, tirzepatide is a combination of GLP1 receptor agonist and GIP receptor agonist. So people usually ask why this combination. In reality, GIP receptor agonist has major effect in stimulating alpha cells of the pancreas to secrete more glucagon. So secretion of glucagon, one of the function of glucagon is increasing energy expenditure. So you are not only suppressing appetite, but you also increase energy expenditure. It also works like PPR gamma, so it has effect on bones. So there is reduction in bone resorption, as you can see here. The effect on adipose tissue is a little bit confusing because it makes it a healthy type of adipose tissue. So we don't know exactly if it causes lipolysis or not. In the contrary, we know that it includes glucose uptake and also lipid uptake. So it gives fat uptake. People will say, okay, this is a lipogenic, like what you get from PPR gamma. But the impact on diabetes will be better because you are clearing lipotoxicity from the circulation by deposition of the fatty acids. But in the same time, you are creating healthy, smaller fat cells. If we look to the efficacy is significantly more than what you had seen with semaglutide. Here is around 22.5% on the 15 milligram dose and around 21.4 on the 10 milligram dose. And for intention to treat, you can see it around 15 to 20% weight loss. But now we started to see more figures. You remember, I said three quarters on semaglutide achieve more than 10%, and now 90% at the highest dose achieve more than 10% weight loss. And 15% weight loss in three quarters, not 50% of the participant like semaglutide, there is three quarters achieve more than 50%. And 20%, around 60%, or a little bit more than 60%, achieve then more than 20%. And we started even to see more than 25% weight loss. Around 40% of participants in the study showed around more than 25% weight loss. So it's very impressive weight loss with this combination. Not only weight loss, you can see improvement in triglyceride around 21%. Also improvement in HDL around 7.5 milligram, and then reduction in LDL around 12.4 milligram 12% from the baseline. So this is a percentage from the baseline. Recently, there is a tirzepatide versus semaglutide head-to-head comparison on weight reduction. And as you may expect, tirzepatide is a little bit more. There is around 20.2% weight loss in comparison to 13.7% weight loss with semaglutide over 72 weeks. And also people who lost more than 25%, nearly doubled from 16% with semaglutide to around 31.6% with tirzepatide. So for weight loss, definitely it looks like at the maximum dose of 2.4 milligram semaglutide and tirzepatide 15 milligram, tirzepatide caused more weight loss and more percentage weight loss. We all know about the side events of those medications, especially pancreatitis. Of course, the risk of pancreatitis is very low, is around 0.34 per thousand, which is very low risk, but in general, it is more in people with severe hypertriglyceridemia, people with previous alcohol abuse, and also people with gallstones. So you have to be very careful when you are selecting this medication or in anyone with previous history of pancreatitis. 2% of the cases of pancreatitis are necrotizing or hemorrhagic pancreatitis, which can be fatal. Also, the risk of medullary cell carcinoma is mentioned here, but it had been seen in experimental animals. So you have to be very careful prescribing it for someone with personal or family history of medullary cell carcinoma or multiple endocrine adenoma type 2. And there is a black box about that. But in my personal opinion, the major alarming side events is the loss in muscle mass. As you can see in the step 1 trial with semaglutide 2.4, the total weight loss is 17.3 kilograms. And out of that, 7 kilograms are from lean muscle mass. This is around 40% of the lean muscle mass. Usually with diet and exercise, the maximum is around 25% of the total weight loss from lean muscle mass. So if you do calculation, you will find that 13.2% of the total muscle mass is lost in just 1 year. And in comparison to age-related loss, here is a step 1 study, and here is a Sermont 1 study, semaglutide and tirzepatide. You can find that around 8 to 10 times the age-related loss. So basically, it's equivalent to the loss in 8 years or 10 years of muscle mass. This is a lot that you can see. And in that review article that we wrote recently, we are talking about mitigation of preventing it by increasing protein intake, high-quality protein, and also by strength exercise. And as you can see with those medication, you will see suppression of the appetite and weight loss, and the body compensate by reducing basal metabolic rate and reducing energy expenditure. But once you stop the medication, what will happen? The appetite will go back up, energy intake will go back up, but because of the loss in muscle mass, the energy expenditure is still low, and that's why people have a significant risk of weight regain after stopping the medication. So in summary, if you look to liraglutide, semaglutide, and tirzepatide, the percentage of people who lost more than 5% is going up. Liraglutide 63%, semaglutide 86%, and tirzepatide 97%. And then if you go more than 10%, around 1/3 with liraglutide, around 2/3 with semaglutide, and around 90% lost more than 10% with tirzepatide. And as I mentioned, people who lost more than 25% of their body weight is around 1/3 in tirzepatide, and people who lost more than 20% is very high in both. 3/4 of participants lost with semaglutide and around 90% lost in people who were on tirzepatide. So there is significant weight loss, and they are all with the same side effects. Now, let us move to the emerging GLP1 receptor agonist for obesity and also for diabetes management. And this is the core of what we would like to discuss today, because we don't know exactly how the future will look like. But let me just tell you that GLP1 and GLP2 and IP1 and 2 and glucagon are coming from one same precursor, the proglucagon. You slice it here, you get GLP-1, and you slice it here, you get glucagon. And if you have two pieces together, this is oxomodulin. The whole idea here, what if you reassemble the whole or part of the proglucagon back? And this is the idea of combining those efficacy together. So the first one I would like to discuss with you is called retatrutide. So retatrutide is basically a triple agonist. So it is not just a GLP1 receptor agonist or GIP receptor agonist. It is also glucagon agonist. And I told you glucagon has advantage in increasing energy expenditure. So you have a potent appetite suppressant and you have potent glucagon stimulation. So what will be the results in using this compound? And as you can see, it came in different doses up to 12 milligram. So you have 4 milligram, 8 milligram, and 12 milligram. Of course, you have the smaller doses, 1 and 4 milligram, but titration can occur, but sometimes even faster titration can occur. Here is the results of the weight loss in the highest doses, and you can see in just 48 weeks, the weight loss is between 21 to 24%. Significant amount of weight loss. We didn't see that before in any other medication. And mind that it is just 48 weeks. And in people with diabetes, usually people with diabetes lose less weight than people with obesity alone. But you can see the weight loss in the highest dose, whether you do a slow escalation or rapid escalation, again, is around 21, 22% weight loss. And people who achieve the A1C lower than 6.5, as you can see, around 80% in the highest of the efficacy. Even people who achieve the lower than 5.7 A1C, you can see it's around 1/4 of patients with diabetes achieve that level. So it looks like it's a very potent medication for diabetes and for weight loss. Again, people may argue that glucagon agonist will raise the blood glucose level, but because it increases energy expenditure, can help weight loss and improve insulin sensitivity to a great extent. We started now not only to see 25% weight loss, which is around 50%, lost more than 25%. We had not seen that with tirzepatide, even in the highest dose. And now we have 30% weight loss. Nearly 25% or 1/4 lost more than 30%. What is very impressive is that the weight loss didn't stop. It looks like there is no plateau. As you can see, there is no plateau. And the efficacy had been way, way higher in people with high BMI. So people with BMI more than 35%, you can see the average weight loss is 26%. And in between male and females, as you can see, it is 28.5% average weight loss. So the medication is more efficacious in people who is very high BMI and also in women. Very effective medication. So the second medication that I would like to also review with you is called the maritide. So maritide is a little bit different. It is not GLP1 receptor agonist with GIP receptor agonist. It's a GLP1 receptor agonist action with GIP receptor antagonist. So people will say, okay, the agonist is causing weight loss. The antagonist is also causing weight loss. And as you can see, it has two receptor activation of GLP1 and two for GIP inhibition. If you do a knockout of the GIP gene in experimental animals, you will see weight loss, which means that antagonist is more weight loss. So, and that's what had been seen in the early clinical trials, and here is 52 weeks trial with different doses, 140 milligram monthly and 280 milligram monthly, so one injection per month, and 420 milligram weekly and then monthly. And as you can see, the weight loss is significant, nearly around 20%. But again, there is no plateau. You can see weight loss. I don't know for how long it will continue to cause weight loss, maybe until people disappear. But in general, it is significant weight loss, as you can see, at all doses. And whether you will give it weekly or monthly, there is less frequent injection and significant weight loss. And more than 98% achieved more than 55% weight loss. And of course, you'll find more people lost 20 and 25% of their body weight. In people with diabetes, again, you will see staggering also weight loss, close to around 17% weight loss, which is also very impressive. And again, whether you will give it monthly or you escalate the dose, definitely it looks like monthly is working very, very well. Those are 3 doses in monthly, 140, 280, and 420. And you can see the weight loss is going on. And again, no plateau, which means that maybe continuation of the medication can cause more weight loss. The drop in A1C is up to 2.2% drop in A1C. So again, very impressive drop in A1C. And at all doses, you can see the drop in A1C is very high. So the medication is powerful. The only reservation here, I told you GIP is responsible on bone health. This is agonist. So there is bone resorption will occur, but so far the data didn't see any indicator of bone drawback or fractures in this population. Plus, extra effect can be seen. You see blood pressure is down by average of 11 millimeter mercury, very impressive drop in blood pressure. Triglyceride is down by 28%. And inflammation, here is CRP is down by around 72%. And I told you about the A1C around 2.2%. So the medication is effective in all metabolic abnormalities in our patients. Then let us move to the third one, and is the first oral non-peptide. It's called orforglipron. And orforglipron is not a peptide, which is a little bit different. So it is a synthetic compound with GLP1 receptor agonist efficacy. So manufacturing will be cheaper, and it can be scaled very, very rapidly because it is a synthetic compound and doesn't need any injection device. The early data with this compound, just 26 weeks, showed at the highest dose, 45 milligram, the weight loss is nearly close to 13%. Very impressive weight loss just by oral medication once daily. As you can see, for 36 weeks, more than 10 weeks more, people who lost more than 10% is around two-thirds or a little bit more than two-thirds. And even in the 36 milligram dose, around three-quarters lost more than 10%. Very impressive weight loss by an oral medication. But if you look seriously in the data for longer duration of the 36 weeks, you will find around weight loss around 15.4% weight loss. So comparable to what you can get from semaglutide injection just by once daily dose. Again, people who achieve the target more than 10%, around three-quarters, and people who lost more than 15%, around 50%. So one in every two will lose around 50% of their body weight by oral use. I think the future will be very brighter in using this medication since it is a diabetes medication. And by the way, the drop in A1C is up to 2.1% drop in A1C. So significant drop in A1C, significant drop in body weight. Also, it can be combined in the future with metformin or with SGLT2 inhibitor because this is an oral medication. And as I mentioned, it will be a cheaper and it can be produced in a big scale. Side effects are nearly the same. 37 to 58% get nausea, mostly mild. Around 14 to 32% have vomiting, and 13 to 32 also have constipation. So the GIT side events similar to what you can get from injectable GLP-1. In the pipeline, there are many GLP-1 receptor agonists in alone or in combination. I mentioned orforglipron, which is oral, and I mentioned retatrutide, which is triple G. There is also another combination of GLP-1 and glucagon agonist. It's called survodutide, and it has very nice impact on MASH. So this is again something that we are looking for. There is combination of amylin analog, cagrilinotide, with semaglutides called cagri-sema. It is in phase 3 right now. And it is a match made in heaven, as you can see, for diabetes, since we have been using amylin for a very long time now, since 2005. But and a long-acting amylin analog is available. And it goes per se by just amylin analog around 8% weight loss. So this very powerful combination, as you can see. And then oral semaglutide, we know it is on the market now up till 14 milligram, but they are testing 25 milligram, 50 milligram, and 75 milligram right now in phase 3. And then apart from GLP-1, there are several other medication in phase 2 right now, either lipolysis modulator, which is a very impressive idea, target only fat. There is also monoclonal antibodies, bimagrumab, which cause more loss in the fat mass without efficacy on the muscle mass, and actually muscle mass increased by 4-5%. And then combination of alpha glucosidase with amylase inhibitor and lipase inhibitor, this will impact carbohydrate uptake in the intestine to a great extent. And again, it is in phase 2. So the take-home message from my presentation is that GLP-1 analogs, semaglutide and tirzepatide, cause significant weight loss in patients with overweight and obesity. And as you see, they are very effective medication for diabetes. The side events we all know, but we have to make an alarming signal that there is significant muscle loss. So you have to give more protein and more strength exercise. There are several GLP-1 analogs or in combination are coming in the future, and they are promising in reducing blood glucose level more than what we had seen before, and also more weight loss. And you can see now people can even reach more than 30% weight loss, even more than what you can get from bariatric surgery. And then, as I mentioned, there is non-peptide, a small molecule, GLP-1 receptor agonist. This is the first non-peptide, and it's the beginning of a new era of giving those medication as a non-peptide in a small molecule that can be absorbed and can be very effective. So in the future, we'll see a lot. And I hope in the next year, when we discuss more, I can get you more information about them. With that, I would like to thank you so much for good listening. And I will hope that we will start using those medication in the near future to help our patients. Again, thank you so much.